Hi, I'm Danielle Backus. In this presentation, I'm going to be talking about pharmacokinetic and pharmacodynamic changes in the elderly. The reason I've made this video for you is I have a practice with Providence Elder Place out of part of my position with Pacific University. I'm on faculty there as an assistant professor of pharmacy practice. And just a little bit of background about me. I did complete my first year of residency training with the VA system. I was in a small VA in Kansas, actually not too far from where I grew up. And then I did a second year of residency at Midwestern in Arizona. In Arizona, there's a lot of geriatric patients. So I did that residency specifically in geriatrics and then to also kind of introduce myself to academia. So my hope with this presentation is to give you just a really quick overview of reminding you really of the pharmacokinetic and pharmacodynamic changes that can occur in the elderly that make drug-drug interactions a lot more likely. And then I'll also briefly introduce you to the Beers criteria. My hope is that a lot of this will be kind of review, so I'm going to go fairly quickly. So I'm going to go through first pharmacokinetic changes, pharmacodynamic changes second, and then talk about how those relate to adverse drug reactions, and then finally follow up with just a quick organization of the Beers criteria. So when thinking back, pharmacokinetics versus pharmacodynamics, if you can remember which one is ADME is going to be pharmacokinetics, absorption, distribution, metabolism, and elimination. Pharmacodynamics isn't quite so mathematical. It's more, 2 plus 2 might equal 6. So it's really how the drug affects the body. So just thinking to yourself, which ADME property is most changed in the elderly and often requires a medication dose adjustment? And just picture an 80-year-old female. So elimination is the thing that's going to be the most different. When you think through your Cockcroft-Gault calculations for renal function, you know that females automatically get 0.85, so older women tend to have especially decreased renal function. Once you get above the age 80, there will be a lot more females to males. I think the ratio is about 10 to 1 after you get past the age of 90, and that's basically just because women live longer. Men have a lot more cardiovascular risks. Okay, so in the elderly, you have some changes beyond just renal elimination. So they overall have increased gastric pH. So that means it's more basic, which seems a little counterintuitive because they're all taking PPIs. But actually, even though maybe they're feeling more symptoms of GERD, their stomach is actually going to be less acidic than the average adult. Also, their gut motility is kind of slowed down. And so you may see some difference in absorption of those controlled release substances. Iron isn't going to absorb as well, which is too bad because that's really the population that we want to get oral iron. But you'll a lot of times see that older adults can't tolerate very high doses of iron, and therefore they may need the intravenous iron, which is also not great. And overall, metformin is more likely to cause diarrhea in older adults. The other thing is if they're using something topical, they do have a thinner dermal layer, and so the medication won't release the way it was really designed to, especially if they are, cachectic or, don't have a lot of extra body fat. And so I definitely saw multiple people getting admitted to the hospital in Arizona because of accidental fentanyl patch overdoses. Distribution. So this is, again, where the drug goes after it's gotten into the body. So overall, older adults do have decreased muscle tone. Obviously, that's, in a spectrum. So overall, if there's less muscle, less protein available in the body, there's going to be less protein binding. And remember that if a drug is bound, it's not going to be active. So that means there's actually more active drug than usual. And that becomes relevant for digoxin and warfarin. There's other meds as well, but those are two big ones. Overall, older adults will have, because muscle has decreased, they'll have more adipose tissue. And so lipophilic drugs are going to have much longer half-lives because they're going to go into the tissue and they're going to slowly come back out of the tissue. So examples of that are diazepam or propofol. And again, there's a lot more, but those are two that I come up with. And then overall, older adults have decreased body water. And we're going to talk about this a few times. But if you just think about it, they're kind of just chronically dehydrated or really close to it. So because they're decreased body water, you're going to have increased concentration of hydrophilic drugs, right? Because you have the same amount of drug, but less water for them to dissolve in. So examples there, alcohol tends to affect older adults more. There's potential some other reasons, but that's one big reason. And then antibiotics as well are Metabolism. So luckily this is actually not too different. Metabolism is largely talking about hepatic elimination. There are some other ways that drugs can be eliminated, but that's the big one. And luckily, an older adult is healthy, hasn't had any, hepatitis or any injuries to their liver. It really should keep working at normal function. The liver is probably our strongest organ and can really, it can take a lot more hits than a lot of our other organs. So it's usually not relevant, but the way this might come up more is you'll probably see older adults tend to take a lot more medications. A lot of medications are eliminated by the liver. And so if they have more and more medications, they're more and more likely to have drug-drug interactions because of liver elimination. So again, unless they have some sort of condition such as hep C, their liver is going to work very well, just as well as the younger person's. But if they're taking a whole bunch of medications, they're much more likely to have changes to their hepatic enzymes based on those meds. So there's an example of a 75-year-old female who's taking fluconazole and warfarin. So this was actually somebody I saw in Arizona again. She had been discharged on warfarin, dosed appropriately for a normal adult, 50, 60-year-old, but she was 85. And she was also discharged on fluconazole. And they didn't keep her in the hospital real long, which is good because you want to send her home. But she then didn't get, to steady state with her warfarin, and she came into clinic probably a week later, and her INR was like 14. So, and I wasn't surprised because she's a little older lady, and they gave her fluconazole, and I know that that's going to have a drug-drug interaction. Luckily, she was okay. There was no major bleeding, but that's, a really, really risky situation. Okay, and elimination. This, again, is the most clinically relevant change. It's probably going to affect the most drugs. So overall, the kidney is one of the organs that tends to kind of poop out earlier than some others. Kidney tends to be one of the things that prolonged blood pressure changes or any injury like from drugs or I don't know, the kidney takes a lot of hits, and it takes a lot of blood supply as well. So it's not that getting older decreases renal function, but the older you are, the more opportunities you've had to have something bad happen to your kidney, and your kidney does get less and less able to recover as you get older. So as I mentioned, it's the most clinically relevant change, and if you have reduced renal elimination, that means that drug is normally prescribed to think that it's going to reduce at this rate, but then your older adult is going to go at this rate, but you're going to keep giving more and more drug. So you could potentially have a longer half-life than what you thought, and you can potentially overdose somebody. So if a drug is renally eliminated, that half-life is going to be longer, and the more highly renally eliminated something is, the more profound the effect. Overall, it's nice if we can just give drugs less frequently. So ideally, you'd want to give the same dose that you would give an average adult, but adjust the frequency for the new half-life that your older adult has. But it's not an exact science. We can't always do that. And so sometimes we do both. Sometimes we'll both decrease the dose and increase the interval. A lot of meds that I'm sure you've probably already done some consults are antibiotics. Other things that come up, so thiazide diuretics overall don't work as well. So it's not so much that they're dangerous, but they just don't have as much effect. ACEs and ARBs can potentially be more likely to cause, marked changes in creatinine clearance or marked changes in potassium in an older adult with impaired renal function. So we still want them to be on an ACE or an ARB because it's renoprotective, but we were going to titrate them a little bit slower if they haven't been on it already. For glyburide and also now glimepiride, those are actually on the Beers criteria, which we'll talk about later, because they have a longer elimination time than glipizide does. And so in an older adult, we want to make sure that they're on the safest sulfonylurea, which in this case is glipizide. NSAIDs overall are more likely to cause AKI in older adults. So if you think back, NSAIDs cause AKI by reducing blood flow to the kidney. And our older adults already don't have as much blood as the normal would because their total body water is less. And so you're taking an already potentially dangerous dehydrated patient to really dangerous dehydrated patient. So again, it's not 100% or anything like that, but NSAIDs are more likely to cause AKI the older you get. And then all of our direct oral anticoagulants are processed through renal elimination. So all of them are more dangerous in older adults. So we've talked about pharmacokinetic causes. Now let's look at some pharmacodynamic causes. So just take a look at this. Which adverse drug events in the elderly can be attributed to pharmacodynamic causes? Remember, that's changes to how something works on the receptors. Constipation or confusion due to two anticholinergic drugs. So overall, anticholinergic effects are more pronounced in the elderly, and because you're talking about a neurotransmitter, it's more of a pharmacodynamic change. Respiratory depression. CNS depression as well as, respiratory depression, it's more likely in the elderly. But there's also potentially some issues with pharmacokinetic changes, such as diazepam, which is highly lipophilic, is going to be stored more in the older adult and accumulate more. And then AKI due to combination of ACE and NSAID, this is really both. This is both pharmacodynamic and pharmacokinetic. So NSAIDs, here we go back to this mechanism, they decrease prostaglandin synthesis, and they cause the afferent arteriole to shrink. ACEs go the other way, and they potentially cause this efferent arteriole to vasodilate. So overall, you've got not that much blood flow coming in, and you can't restrict the blood flow going out. And so the kidney can't then regulate this glomerulus to maintain a good pressure. So you're really making it difficult for the older adult to maintain stability, especially since they're, like I said, kind of chronically dehydrated. So that's kind of your pharmacodynamic effect. But the pharmacokinetic change, again, they're more likely to have issues because of this reduced renal elimination. So that's, and a lot of things will kind of go in both categories, both pharmacokinetic and pharmacodynamic. So as I mentioned, older adults are more likely to have CNS depression. Overall, they have less available neurotransmitters in the brain. Over time, they've had more opportunities, again, to have brain damage. Also, medications cross the blood-brain barrier easier. So some example medications that can cause more CNS depression. Ethanol, I know it's not necessarily a medication, but it's something that can really mess with a lot of medications, especially in older adults. And then anything that's sedating, so benzos, opioids, including tramadol, zolpidem, all those things really can cause some significant CNS depression. And you might also see it with meds that you wouldn't have thought based on younger adults. So, for example, I've heard of older adults getting just completely out of it just from a little bit of baclofen, whereas in a younger adult, they'd be fine. Really anything that has CNS sedating properties, you want to start really slowly and really monitor them closely. And if possible, get them off. A lot of our CNS depressants, however, are for quality of life, not necessarily quantity. So think things that treat seizures, things that treat pain, all of those things are really important to palliative care. So we may not be able to get rid of them, or else our patient would be really uncomfortable. But we want to make sure we're doing our due diligence to make sure that we're not sedating them too much. Anticholinergic effects. So again, you're blocking the actions of acetylcholine, so that's why it's a pharmacodynamic effect. Over the short term, you'll see those classic things like constipation, dry eye. Long term though, especially for older adults, you can have more cognitive impairment and even potentially dementia. Donepezil is a acetylcholinesterase inhibitor. So donepezil increases acetylcholine. So every single person who takes that inherently has a drug-drug interaction with any medication that decreases acetylcholine. And you'll see oxybutynin, potentially TCAs, diphenhydramine, anything with a strong anticholinergic property is going to have a drug-drug interaction with donepezil. And that does make sense, again, that anticholinergic meds can potentially cause cognitive impairment because we use donepezil to increase cognitive function. And then again, similar, you're going to have drug disease interactions with dementia because one of the primary problems in dementia is lack of acetylcholine. So older adults are more prone to these issues. One, because of the same issue, they're chronically dehydrated, not as much fluid, not as easy to move. Another thing is their excess presence of catecholamines actually causes downregulation of beta-1 receptors. So because there's these extra catecholamines floating around, those beta-1 receptors have decreased, and then the heart can't necessarily keep up as well. Baroreceptors, which are responsible for sensing these changes and making sure that blood pressure stays normal no matter what, they don't work as well. Also, a lot of times in older adults, you'll see that they have a really different systolic blood pressure to their diastolic. I'd say it's really common to see somebody with 140/60, and that's a huge gap. And so having isolated systolic high blood pressure increases the risk. Now, there's a lot of medications that can cause orthostatic hypotension. Beta blockers are much more prone to it in older adults, especially at higher doses. Clonidine, Flomax, tamsulosin, terazosin, which is like the older version of Flomax, any diuretic because you're making the patient even more dehydrated, and then antipsychotics. Now I'm going to go through some different events, and I want you to think through to yourself, what are the pharmacokinetic and pharmacodynamic causes? We've got an older adult, they have large bruises, their INR is too high, and they're on warfarin and Bactrim. And the drug-drug interaction here is that Bactrim decreases metabolism of warfarin. Second one is a 90-year-old female. She's taking nitrofurantoin, but her UTI isn't resolving. And just so you know, nitrofurantoin requires adequate renal function to even get to the urinary tract. And one more, I got a 70-year-old male. He's had a bad fall, and he takes these 3 meds, lorazepam, terazosin, and paroxetine. Lorazepam can cause CNS depression. Terazosin can cause orthostatic hypotension, and paroxetine can cause anticholinergic effects. So in our Bactrim case, I mentioned that it decreases metabolism of warfarin, so that right off the bat, you know it's definitely pharmacokinetic changes because the metabolism's been altered. But now that you have more warfarin available, you can actually have a pharmacodynamic effect as well by changing the clotting cascade. For somebody whose UTI is not getting better with nitrofurantoin, that's honestly a purely pharmacokinetic issue. So that older adult, their renal function isn't good enough to get it to the site, and so there's not going to be an effective way for the nitrofurantoin to get to the bacteria. Also, nitrofurantoin has a lot of nasty side effects if it accumulates, so that is one that we have to be careful with. And then somebody who's had a fall, all of these adverse effects are more likely due to pharmacodynamic changes associated with aging. So there's all these different receptor issues here. So we've all probably heard of the Beers criteria, but let's remind you what's in it. So they call medications in the Beers criteria, whatever is included in the Beers criteria, is a potentially inappropriate medication. Potentially being a key word. So it's not a list of drugs not to use, it's a list of drugs that could potentially be inappropriate. So things that require a little extra attention. The first table of the Beers criteria is just talking about how they organize evidence. So sometimes you'll see, I called them table 2 in here because that's the structure that they use in the published 2019 guidelines, but you'll see them called different numbers. Just know they go in this kind of general order. Things that show up in the first table are potentially inappropriate medications for all older adults. So these are kind of our medications best avoided for everybody if possible. Then the next one, you have to know what specific disease or syndrome the person's having, and then look to see if there's potentially inappropriate medications for that. The next table is a little bit less of a warning. They're saying that these are more things to use with caution. So these aren't quite as high priority as the first 2 tables. There's some drug-drug interactions that are best avoided for all older adults, and I would take that very seriously. And then a list of meds to be renally dosed, not including antimicrobials, because we know that so many antimicrobials require renal dosing. So there's a few examples. These are pulled from the 2015 criteria, so if there's any changes, I added it. So nitrofurantoin, it says to avoid for individuals with creatinine clearance less than 30, or for long-term suppression of bacteria. And here's some of those nasty side effects I talked about: pulmonary toxicity, hepatotoxicity, peripheral neuropathy. And the reason that somebody might be getting this long-term is because they've had a lot of UTIs and they're trying to prevent them from having a future one. For these people, I always say, let's try getting them off of it, because a lot of times, as long as they're staying hydrated, they don't need that chronic therapy. This is specifically for the non-benzodiazepine, benzodiazepine receptor agonists. So, or we a lot of times call them Z drugs. These have really similar properties to benzos, and then they have a few extra things that are bad. So really, there's no benefit at all in older adults to using these. They cause just as much delirium, just as many falls. Those were both examples of things from that first table that really lists out meds to generally try to avoid for everybody. Now, these are meds to try to avoid if they have certain disease states. So here's that example again of people with dementia, and you can see the anticholinergics is specifically called out. But then they also include anything else really that causes a decrease in cognitive function. Aspirin. So this is one update in the 2019 version. Here they say This is in, again, the table that talks about using meds with caution. So not necessarily meds that they say you should definitely avoid, but meds to consider, do we really need this? Or what monitoring should we do to make sure that like we're really being safe with this? So overall aspirin, we see a lot more bleeding with aspirin in older adults, and the benefits of stroke prevention isn't quite as strong once you look at that bleeding risk. So in the 2015 version, which I have for you here, they said to use with caution in anybody older, 80 years old or older. And the new 2019 update has actually decreased that age all the way down to 70. So that's most older adults. And again, this is only primary prevention. So if somebody's had a stroke before, yes, they're going to be on aspirin. These are drug-drug interactions to try to avoid. So you'll probably see a lot of people that are on amiodarone and warfarin. Overall, we really want to try to avoid any NSAIDs with warfarin. And kind of going back to this previous thing about reducing the use of aspirin in those older than 70, we also try to reduce the use of aspirin with warfarin in older adults unless they have a really compelling indication.